Hello, everyone. Welcome to the second of this series of four podcasts where we're reflecting on and discussing the four papers that have considered standards for the care of people with cystic fibrosis. Today, my name is Kevin Southern. I'm a professor of child health in Liverpool, and I'm the current director of the Standards of Care Committee for the European CF Society. Today, I'm delighted to be joined by Chris.
Hi everyone, good morning. So I'm Chris. I'm a pediatric CF dietitian by background. I'm also currently the director of education and a very happy co-author of this paper. Thanks, Kevin.
And by Silke.
Hello, everybody. My name is Silke van Koningsbogen-Wietschel. I'm a pediatric pulmonologist and the CF Center Director of the CF Center here in Cologne, Germany. And together with our pulmonologist, we are taking care of children, adolescents, and adults. And I'm looking forward to this webinar.
And you're now the deputy president of the society, Silke.
Yes, that's true.
Yes.
Thanks, Kevin.
So thanks very much to Chris and Silke for joining. Those of you who may have had chance to join the webinar last week will understand the style of this, but just to reiterate that we're going to be reflecting on the content and what we consider to be the key messages of this paper too. And really we're doing this to kind of put the paper into context, to put this series of papers into context. We don't really expect that this will replace reading the papers, and we would strongly encourage you to read the papers because they're very good, really excellent authors, and some really informative pieces. So really, this is an added bonus, if you like, to the papers. But hopefully, after listening today, you'll have a good idea about paper two. So you'll remember, some of you from last week, that we divided the this exercise into themes, and paper two explores the second theme, and then we subdivided the themes into topics and then sections, and we invited contributors to each section, and they worked really hard and very quickly, and the whole process was done in a very timely manner. And the contributors to each section also provided statements which were then reviewed through a Delphi process. Many of you might have contributed to that process, and that was really helpful as well in adapting and developing the statements. So that's essentially the process that we undertook. It was still a very strongly evidence-based process, and we asked all the authors to do an extensive literature review for their sections. But because their sections were quite small, they were able to do this in a very timely way. We had a core committee, and Silke and Chris were both sat on the core committee, and I have to thank the core committee again. They worked really, really hard to review every single section that came in, and to help with the modification of the statements and so forth. So that's how we developed these four papers. Now, paper two, to me, was possibly the most exciting of the four papers, in that it really changed the approach to developing these standards. And this came from our interaction with CF Europe and with stakeholders, with people with CF and with their families, talking about how do you want this to move forward. And very much the message that came through to us was, we don't want CF to be considered to be a problem that needs to be solved. We want CF to be considered to be a potential, an exciting potential to have a healthy and enjoyable life. And so the basis of this paper has changed from previous standards, which very much looked at cystic fibrosis as a problem-based exercise, and more moved towards establishing and maintaining health. And people said to us, oh, you can only do this because of modulators, which a large number of people with CF are now eligible for, and many have access to. But actually, Silke, I think this kind of predates that, really. I mean, even before modulators, we were seeing significant improvements in the well-being of our pediatric populations.
Yeah, you're right, Kevin. And I also really like paper two. I think that's a really exciting paper. And as you said, early treatment is allowing people with CF to first, and that's one of the key messages that we will discuss, excellent nutritional status. And Chris, I guess you will comment on that as well. We can reach and maintain lung health, and we can establish a healthy and active lifestyle for our people with CF. So this is in reflection of the key messages we will discuss during our webinar. And what I really like a lot is the title, because it states establishing but also maintaining lung health, and this is something that looks into the future. So and the future has really transformed for people with CF independently of the CFTR modulators. And there's another term, Kevin, I really like. It's staying ahead of the curve. And this implies the importance of what we can do for maintaining lung health. And then there's another topic on, and I really like this term, on variant-specific therapies. Of course, they have transformed clinical outcomes for people with CF. And the paper reflects very well the changing CF landscape. And this applies to people with CF with and without variant-specific therapy. And then throughout the paper, there's always the message of partnering, of shared decision-making. And this is something we've learned a lot from CF Europe, like you just stated, but also to have an open mind for innovation in the future, maybe also different approaches. And with that point, we come to the discussion of new models of care. And one of the key points we will discuss, I guess, also is still that the multidisciplinary team stays crucial. Whatever we will discuss, this is so one of the core. And also, Kevin, we would like to thank you for your enormous job, because you have led this large project and all those 4 papers. And this was so much work. You really worked so hard. You were an excellent team leader, and what we all accomplished together is 4 papers in 1 year, and this was just amazing. So big thank you from the whole CF community at this point.
Well, it was a big team, and actually, just at this point, I mentioned Fiona Dunleavy, who was tremendous in pulling it all together. Chris, shared decision making. Everybody talks about shared decision making this, shared decision, but people really don't get what it is. I don't think. Well, some do. Somebody said to me the other day, shared decision making is about giving the patients 2 options and asking them which one they want. But that's not shared decision making. Yeah.
I think it's a really good point, Kevin. I think that's what this paper really draws out really nicely. I mean, apart from the fact that there's lots of things I enjoy about this paper, and I think the proactive ethos that goes throughout this paper is really good, and that balance between optimism and kind of realism is also laid out really nicely. But yeah, you're right. This shared decision making is a really important part of it, and I hope that the understanding comes from this, that's the engagement of the whole MDT team, which has obviously become broader and it's become wider, and there's more opinions that we need to take, and more people's thoughts that we need to consider. So I think that does really come across nicely, and I want to, emphasize that MDT approach, as well as engaging the families and the person with CF and the wider kind of community around them, is really important, and I think that does come across.
It's a really difficult part of your professional life to turn around to a young person with CF or an older person with CF and say, where do you want to go? What are your goals? What are your aims? And how do we get there together? How do we work in partnership to get you there? And we as healthcare professionals, we're not really trained to do that. We're trained to just tell people what to do. It's very much that sort of training. So I think But in the world of cystic fibrosis, we've moved ahead much further than many have. But that's a very important change of direction. Anyway, we've already kind of messed up a bit because we're supposed to start these podcasts with the three key messages. So myself, Chris, and Silke have sat down together, and there are so many messages in this paper. And again, we recommend that you have a good look through all the papers, but this one. But the three key messages that we have outlined, and we'll say those now, and then we'll say them at the end of the podcast, are one, that achieving excellent nutritional outcomes is key to a healthier life. And the whole CF team should work in partnership with people with CF to establish and achieve this goal through a high quality diet. Now, we'll come on to that later on, and Chris will expand on that a bit. The second key message is that it is critically important for people with CF to exercise on a regular basis. Now, there's some elements of this that are really challenging, but this is very new for the standards. I mean, we've alluded to exercise in previous standards, but in this paper, we have many sections covering this topic. And I think that was really one of the most important and innovative aspects of this paper. And the final key message is that and we had a really tremendous group, a really experienced group, writing and reflecting on models of care, and from that you can get the key message that as the CF landscape changes, with most people now established on CFTR modulator therapy, there is potential for examining models of care and how we deliver them. But access to the multidisciplinary team, as Silke said earlier, remains absolutely essential. So those are, and those three statements actually correspond to a number of key messages. They correspond to a number of statements within the paper. So first of all, then, Chris, we'll work through the paper in a logical manner, and we'll start with the section. The section that is staying ahead of the curve is that Silke mentioned is the section written by the physiotherapist, and I do agree, Silke, that's an absolutely lovely turn of phrase that they use. But the first section was on eating well, and this covers a lot of ground, Chris.
It does. And I'm really happy, Kevin, that this comes, early in the papers, because I think it reflects something really important and really positive. And that is that we are planning for longer lives. And that should start with the consideration of nutrition right at the very beginning, recognizing that the nutrition we provide all of our babies, has a lifelong impact and hopefully can have a positive lifelong impact. So you're absolutely right. We talk about, I think the fourth key message here is the recommendation was about promoting healthy eating behaviors, and so I wanted to just kind of expand on that if I can. What we were trying to draw out there was the encouragement for people to think about not just what they give their children and the people that they look after or what they eat themselves, but also how they eat and how they feed themselves and their children as well. So by that, what I mean is, what we eat is obviously the focus is very much now not just on quantity of calories, but it's about the quality of the diet. This big shift to consider the importance of diversity, understanding the influence that those nutrition aspects might have in longer term health, and the how part of it, thinking about how we eat, that's recognizing the role that food and nutrition has in supporting healthy behaviors and body image. So it's about teaching children to listen to appetite cues and encouraging a love of food and a curiosity about it, and not too much stress, and promoting diverse development of foods and tastes. That's all really important. But I wouldn't want people to think that promoting healthy eating behaviors is just limited to babies or young children, because we recognize that can occur on all ages. So in adolescence, we wanted to draw out the importance of thinking about food and meal times, about a time to connect with friends and family, not just about calories, which it may have done in the past. And even in the adult world, considering mindful eating, as a healthy eating behavior. There's some great work on that ongoing at the moment that really illustrates the importance across every age spectrum of enjoying the food you eat and seeing the benefit of it.
It's a difficult balance, isn't it, Chris? And Silke, you probably have this in your clinic. The first thing we do as the babies and then the young children, the first thing we do is put them on some weighing scales, judge the parents on how the children are doing weight wise. And the section written by Tanya, but together with two psychologists, Eddie and Monica, is absolutely smashing, where they're considering how we as CF teams all work together. So we all work together to sort of reflect on how we interact with the family, and actually don't make them completely sort of like tightly coiled springs around weight, and then the issue around the children and young adults who have gone on to modulator therapy, Silke, that's also been very tricky, because they have established eating patterns, and now some of them have actually gained rather too much weight on modulators. Not all, but some.
Yeah, and Chris, I can fully agree with all what you've said. And Kevin, in the years back, we always focused on the quantity and eat, and we add fat and additional calories. Then we focused a little bit more on the quality. And what I really like about this chapter is the psychosocial and the psychological aspects. And I think this becomes more and more important. And there are also some really clear examples, which I really like, to encourage healthy feeding behaviors around the meal and to socialize. And that's a good opportunity for the family coming together, for socializing, for connection, involve the children in meal planning, and give them a good feeling for eating. So that's very, very important. And that's also very important, Kevin, what you now said about the CFTR modulator therapy. We need psychosocial and psychological methods now to change what we have dogmatically told our patients: eat and eat calories and focus on a good weight gain. And now we have to somehow educate the opposite. Look for less calories and still for the quality and the psychosocial aspects of the meals. But we have to adapt our recommendations now. And this is really a challenge, because we know from our personal life, if you've been doing things for 10, 20, 30 years, it's hard. It's very hard to change them. And that's really a challenge. I really like this chapter because it also gives some practical advice for psychosocial aspects we can now use to a little bit modify our recommendations.
Yeah, I mean, essentially, fat tastes really nice, and that's why you get a taste for it. And really, the high calorie, which were essentially high fat diets that were so successful, we were able to advise those because we had the acid resistant pancreatic enzyme replacement therapy, and that really transformed CF back in the 1980s. And I kind of started in CF in 1989, so I kind of was at the back end of that, where we were beginning to realize that actually we can address the nutritional. So now we've gone like full circle, and it's fascinating. But Chris, pancreatic enzyme replacement therapy remains key, and the recent issues that we've had in many parts of Europe around access to enzymes has been really disturbing, and sort of has highlighted what a vulnerable position we are in as a community, really.
It has, and I'm glad that you bring that up, Kevin, because it is something that we're very aware. The RCF community, nationally and internationally, it is a source of extreme stress and concern. There is a great section in this paper on pancreatic enzymes, and Dimitri did a great job at working jointly with this, as always. I would say, for context for the situation we're facing at the moment, there's something important in the standards of care, and that is that we do recognise that there has been a broad shift, possibly, in pancreatic status, or the possibility of pancreatic status as a result of modulators. And we saw that with some of the early work with ivacaftor, with some shifts in improvement, and in some case resolution of pancreatic sufficiency. And we've seen it in more recent data with ETI in these younger children. And that's not necessarily reflective of all the data globally. We know the data from the US, from the PROMISE study, doesn't suggest quite such a shift. But I think what we've recognized and what comes out in this paper is that there is a possibility for improvements in intestinal absorption and intestinal reduction of intestinal inflammation, which might influence the need or the extent of pancreatic enzymes. Now, I would say that this has also coincided with this big shift that we've seen in global access to pancreatic enzymes. So we know this has come about from an increase in demand. There's been manufacturing challenges, there's been regulatory issues, there's been supply chain disruptions, and there's overall sort of increase in use. And we're very aware of some countries that are struggling now. So the UK, Ireland, Spain. We've had reports from southeastern European countries, and even some concern from Australia as well, that this is a problem. But I think we need to be clear, that yes, there may be some change in pancreatic status in some patients with modulator use, but that is no reason to alter the doses that we give. The rationalization of PERT doses should not occur in response really to shortages, but really in response to careful assessment of pancreatic status and careful assessment of nutritional sort of assessment and situation. And I guess it is a concern for us because there are certain patient groups, right, that are particularly vulnerable to inadequate PERT doses, infants, adolescents that are going through major growth spurts and pregnancy, so we know that there are real key areas. So yeah, it is a big concern. I would say we are trying to act on this, and we are seeking out solutions such as prioritizing distribution and seeking alternative formulations and advocating for increased production. So this is happening, but you're absolutely right. And Silke, I don't know your experience sort of with you locally about the situation. Is that something that you're finding as well?
Yeah, we have the same issues in Germany as well, that availability is reduced at the moment. And I think the question is a really important question, although we do not proactively ask the patient to maybe reduce their enzymes. But from our experience, many patients have already done it or tried it, or tell us, I've forgotten to take my enzymes, and the reaction is not the same that I used to experience. So there are no loose stools or bowel ache, or flatulence is much less. So they empirically, individually might have already reduced their enzymes. But I think it's nothing, the evidence is not there yet, and we cannot proactively recommend it.
That's the key message, isn't it, Silke? That you've got to keep working with your CF team, and particularly with your dietitian, if you're making these changes, because it's a period of flux, and there is some potential. Potentially, you could get a bowel blockage, or so. I think people with CF may be adjusting the PERT dosage, but they need to be doing this. We're working together with their CF team. We're going to have to move on. There's a lot to cover in this paper, and we're just on the first topic. So the second topic, which was staying ahead of the curve, was written by our physiotherapy colleagues in his tremendous section. I particularly like the way it kind of frames adapting techniques as the young child grows into an adult, making them more independent and so forth. It frames that really nicely, and I would recommend it. And they talk really good section on rhinosinusitis as well. But I'd like to move on to clean air, because that is quite an innovative section of the paper, Silke, and this is the first time for any chronic disease, actually, but it's the first time where a statement has been pretty categoric that people with CF should not use e-cigarettes, or that's commonly called vaping, and that got very complete consensus within the Delphi process. So it's a strong statement. It's quite Silke, how do you, well, you obviously strongly support the statement, but actually then translating that into practice, where some young people with CF may think, oh, well, actually vaping might be a safer way for me to we've lost Silke, to interact with smoking than actually smoking tobacco-based products.
Yeah, I think that's a very, very important chapter, like you stated, Kevin. And I think it's the the first chapter or the first paper that really gives this clear statement. And I think the evidence that people with the CF should not smoke, this is unequivocal and it's widely accepted, so that's clear. But many people think, and that's not only people with CF, but also in the general population, that vaping is less harmful and therefore somehow acceptable. So they tend to trivialize e-cigarette smoking. And indeed, this is the first paper that's clearly stating that people with CF should avoid e-cigarettes. And that's always the first step, that you give a clear statement. And it's also explained very well, also in detail. It may contain very high level of nicotine, which can make patients highly addicted.
I don't think that's well known that actually e-cigarettes have a higher most e-cigarettes have a very high concentration of nicotine and are therefore very addictive, and that's one of the problems in supporting young people coming off them. So you need to consider using nicotine patches or a nicotine withdrawal service. Chris?
No, I think one of the things that I think was really important from this section was that recognition of the importance of discussing this with our patient group and recognizing that those discussions happen early, in pediatrics, and that most recent data suggesting that you can identify likely situations. For example, those people who have higher levels of anxiety, seem to be, from the data, more likely to go on to use e-cigarettes. And so we can target those people for providing that exact information that you're talking about to actually try to prevent it from happening, and recognizing that we need to do that perhaps earlier than perhaps maybe we've done in the past. So yeah, those identification of the trigger or the risk factors for it, I think was really important.
Yeah, it raised lots of really good issues, and if you're doing that in standards, it's great, isn't it? And like, I'd never even heard of hookah smoking, so that's new to me, and we've also advised against that. Quite for the social aspects of it, but haven't got time to go into that. So we move on now to what I think is probably one of the strongest sections, one of the strongest topics in the paper, and that's around being active. And as I mentioned before, we have alluded to this in previous standards, but this is the first time that it's been really, although there are very good ECFS recommendations with regard to exercise and exercise testing, this is the first time it's been in a generic standards of care paper. So I thought Thomas, Zoe and Anna did a really tremendous job on this, and they talk a lot around joint decision making, identifying goals and aims, and it's really hard. Everybody should exercise. We all should exercise. Despite my appearance, I cycle regularly, but we should all be exercising. But actually getting that motivation is really difficult. And for people with CF, it's kind of non-negotiable, and that's a difficult concept to have. If you want a good quality of life and a good life expectancy with CF, even if you're on CFTR modulator therapy, you need to be engaging with exercise. And they make that distinction between, walking the dog, which is an activity, lovely activity. So, and exercise is actually different. Exercise is where you're really feeling it. You're feeling like you've done something that's not easy and is quite actually making your heart race and yeah. So Chris,
I really enjoyed that section. I think I agree with you. They did an amazing job and they picked out some really important things. And I think for me, it was their identification of some key factors that might help to improve engagement. They said, offer choice, offer diversity or support diversity of exercise options, and be flexible about when we offer it, and appreciate that for some people it's more important at some points in time and less important in others. And I think I found that really helpful. I also really liked the recognition in that section that we all have a part to play in encouraging and supporting exercise. So, yes, the physiotherapists may in the past, the assumption would have been that they may be the main drivers, but actually, our psychology colleagues, they've got a role there in goal setting and helping to identify barriers. The dietitians have got that role to support nutrition to support engaging and recovery of activity, and pulmonologists, their encouragement and their context of exercise in overall health. I think that's great. So I really enjoyed their section. I think
that's a common theme of all the papers, I think, Chris, but particularly this one around, like, we're a multidisciplinary team, but we shouldn't be working in silos. We should be supporting, everybody should be supporting each other to give common messages and common goals. Yeah. Silke, one of the I'll be careful what I say, otherwise Thomas will be emailing me. Well, but one of the issues around this section for me is around monitoring exercises. It's quite tricky, and I think they've written a really nice section on that. But actually, how often to monitor, how to monitor is still, it's slightly not completely defined. And I think for me, I know my service has taken away from this, that we should be doing more regular cardiopulmonary exercise testing. So for people out there, that's often when you put somebody on a stationary bike and you're measuring all sorts of output from that, and you can get a really good measure of their Vmax and their exercise capability. But that's quite an involved test. And then if it's not great, how do you feed that back to the patients? Or if it is great, how do you keep it being great for years and years and years? How often do you do it? So although the evidence, the statements are there, it's still slightly up in the air to me as to what exactly we should be doing and how often. I don't know. Is that being a bit unfair? Yeah. But that's because we don't know, and I know Thomas and Zoe are working a lot on this to try and sort of give us clearer.
Yeah, Kevin, that's the same in our center, and the whole team, like Chris, like you said, it's so important to motivate doing exercise. And then it's not even clear how often do you have to exercise, what kind of exercise, which program, how is the disease severity. So Kevin, you're right, we need to test it, and we have an exercise working group and a physiotherapist special interest group, and they have provided some exercise tests. But I do not know how very well they are established in the various centers. And like you said, Kevin, also in our center, especially in pediatrics, when they go to rehab and they stay there for 2 or 3 weeks, that's a good opportunity to really test on exercise and establish an individual exercise program. But again, for children, it's much better if they perform in a sports club, or they have something they do and it's fun and it's not like therapy again. So maybe it's different in the adults, where you have those mobile bicycles at home and you can really set up an individual training program and then recheck it or do spiroergometry. But in children, Kevin, I agree, in our center, exercise testing, it's more included in the physiotherapy session. And it's a task of the multidisciplinary team, Chris, like you said, to motivate and to engage in adherence, and also to point out at every visit how important it is. And what I also liked about this chapter is that they seem to differentiate also a little bit about exercise and physical activity. So physical activity is something you include in your daily life and it's easy to manage, but exercise is really more stressful and needs more adherence, and they combine it. And to really engage in physical activity and exercise, that's a topic we have to address at every visit.
I agree, and I think you're absolutely right. I think I also really like it. It was a very holistic view of activity, and I think that was really beneficial. And I noticed, the inclusion, the highlighting of the impact of exercise, not just on lung health, but on body composition, was drawn out in that section as well. I think that's so important to recognize that body composition is a new target that we need to be focused on, and that has benefit not just with pulmonary function, but with glucose and with bone health and with inflammatory markers as well. So I did like that kind of holistic view of looking at all the elements surrounding exercise and activity.
Yeah, fully agree. And Kevin, then we come back to the variant-specific therapy implementation and the weight gain. So exercise motivation even becomes more and more important. Yeah.
and I kind of feel that the section does sort of say you need to individualize things because some of our patients and older patients and so some of them have a sort of eureka moment and then become incredibly dedicated towards keeping themselves in very good physical shape, very motivated, but some of them it like going to the gym does not float their boat, as we say in the UK. And so you need to be very, for all your patients, you need to have a strategy of how you support them, how you find something that they can do that they can maintain and do for their life. It's one of the biggest challenges that we face, and we need to do that as a team, not just the exercise physiologists and the physiotherapists. That kind of takes us on nicely to the next section, which is called working with the CF team and other healthcare professionals. So I kind of the thing I liked about this topic was that it was really framed around the person with cystic fibrosis and their family working with the CF team and what they should expect from their CF team. And it built very much on previous standards, which have set out a very clear picture of what a CF service should involve, and essentially, I think it lays that out very nicely. But it kind of says, look, we're in a flux, and we need to keep very open minds around how we move forward. And there's a really good section on remote care, remote monitoring, and actually virtual clinics and ambulatory care that's written by Charlie, Michael, and Ilan, who is a man with CF in Israel, and they highlight some of the exciting potential for that, but say that this needs to be framed around people with CF, how they want to move forward, and how we can provide them quality. So we're not eroding quality of care by taking on these different sort of approaches to care. And the emphasis on the multidisciplinary team remains really, really important. And we, as across the globe, we may potentially be in a position where it's difficult for us to maintain multidisciplinary teams moving forward because health services are restricted in funds that they can give, and they will be saying, well, modulator therapy is not inexpensive, and we would. Do you still need this large multidisciplinary team? So this document clearly says, yes, we do, and this is how we move forward. It also, and very interesting to me, and this actually is reiterated in the next section, which is around managing medicines, but it highlights the important and really specific role of having a pharmacist embedded within the team who is CF specific. And kind of this is a very standard thing in the UK, but I was surprised from this exercise to hear that this is really less common in Europe, Silke, and I think that with new innovative therapies coming along, which actually the dosing of those therapies is quite complex. Well, I personally find it quite complex, particularly for children. That having the support of a pharmacist is even more important now than it's ever been. Yeah. So, Silke, I mean, what's your experience in Germany with regard to having a pharmacist embedded within the CF team?
Kevin, I wished we had a pharmacist in in our team. I think this is something really unique in the UK, and we also know it from the US and in other many European countries. The pharmacist is not an active part in the MDT, and I think that's really a pity because it like you said, Kevin, it becomes more and more important with the CFTR modulator therapy, but also with other medicines like optimizing drug delivery and the whole management and review all the drugs together, and then
how those medicines interact with modulator therapy.
Drug interactions and difficulties to adherence, and also how they take their drugs and so on. So we have a lack of pharmacists because we do not have a hospital pharmacy for outpatients, only for inpatients. So our patients go to their local pharmacy, and there's hundreds, thousands, and we are not in close contact to them. So the other team members have to take over this role, which is really challenging. And that's also a potential for the impact on quality of care, Kevin. That's right, and I wish we had that. Sometimes how we can get around is that we ask the pharmacologists, and that's an institute here. And it's really, it's quite interesting. Like one time we sent them our list of medicines from a lung recipient patient, and he was taking like 20, 25 different medicines. And then we had a whole email answer, what we have to take into account and what we have to change and where we have to draw peak and trough levels. So I think that's, Kevin, that's a really important role. And
very important, probably less helpful than the pharmacist, though, who just gets on and does all that. And you know, we have experienced quite a few adverse events following establishing CFTR modulator therapy on some of our younger patients, and not all serious, some transient and rashes and so forth, but our pharmacist has reported all those AEs, has reported all of them to our national data bank for that, and that's really important. Chris, were you putting your hand up there?
Oh, it's actually scratching my face, Kevin, but I will add that, I mean, I completely agree that it's such an important section to highlight pharmacists and their roles. And I think, you know, it has been perhaps an area that's been maybe underdeveloped, and we do see a huge variety of the roles that they take between different countries. And certainly, you know, working with CF Europe in many sort of middle income countries, you know, we've seen firsthand the real challenges that there are to establishing a pharmacist in an MDT team. You know, you've got kind of infrastructure issues, you've got education and training that may not be as comprehensive as high income countries, you've got regulatory framework, so that may be a bit underdeveloped in some places, and in some cases there's the perception of a pharmacist as well, which may be for some people that they just dispense medications, whereas of course in our experience we see the whole host of roles that they do, and I think some of the issue has been the lack of clarity about what the pharmacists can do. And I can never resist the opportunity to talk about education, of course, but I would say the pharmacy group have developed a syllabus which is on the education platform, which clearly defines all the different roles that the CF pharmacists can take on and the knowledge that they would require. And I think that's such a helpful document for centres that are looking at these standards and they're reading how important pharmacists are, but they want to know what is it they exactly do or can do. And the syllabus really helps to feed into that, I think.
Yes, definitely, Chris. And the comments, Silke, that we had in the Delphi process, the exercise, echoed your comments around, well, we're struggling to get a pharmacist, but we would really like one. So hopefully this statement within this paper will help people to be able to make that argument. And certainly Chris's resource in the education framework is really valuable. Don't think we have time to talk at more length around the virtual clinics, but just to say that the Standards of Care Committee, and we still have a core committee who are very active, we appreciate that this is an area that's in flux, and we're going to be keeping a close eye on this moving forwards. And we want to work with CF Europe, with people with CF and their families, to try and better define models of care as we move forward. But I think this is a great section in here, a lot of really good practical advice for people in how they actually do virtual clinics, and we'll recommend it to you. So we've now segued nicely into the managing medicines section, and we've talked about the role of the pharmacist, but in this section, which was again came from people with CF saying, look, medicines are an enormous part of our life and we want a section that's devoted to that, addressing the issues. One of the issues is around adhering to therapies, and we talked about the number of different ways of monitoring that, and that CF teams should be working with their patients and with their families to monitor adherence to the various therapies. And there are a number of different options and ways of doing that, but it should be done in an open, transparent way with families to sort of work in partnership with them to try and support them then to be able to improve their day-to-day adherence to therapies. And we talked around some of the strategies that might be employed to do that, but it is challenging and it's individualized, and we appreciate that. And then there's a very nice section on starting and stopping therapies, and this is something that we've had questions about actually before the podcast today. What is the evidence base? And it's really difficult. We're in a kind of evidence-free zone. CFTR modulator therapies have become established. It's evident that they have good outcomes. It's evident that people with CF feel differently on these therapies often. And it's also very clear that people with CF want to rationalize their treatment burden, have less of a treatment burden. But we can't at the moment turn around to them and confidently say, well, maybe you could do less nebulized therapies, either nebulized antibiotics or nebulized hypertonic saline or Dornase alpha. We don't have that evidence base at the moment. And this section is written by Gwyneth Davis, Martin Pluger, Nicole Meyer-Hamler, and Bradley Quinn. And they very nicely outline the lack of evidence, but they do outline the fact that there's quite a lot going on. Some actual randomized controlled trials, some proper trials, some over short periods of time like Simplify, and some over longer periods of time where we don't have the data yet like CF Storm, but also registry data looking at the real world evidence, observational of what decisions have people made since they've become established on CFTR modulator therapies, and how have they progressed since making those decisions? And so there's a lot of evidence coming along. We're not quite there yet. The Simplify studies were initially reassuring that over the short term that it might be possible not to have a significant deterioration in respiratory well-being and function, but we need to keep a close eye on this area, and we'll see over the next 2 years an increase in evidence, so we're able to sit down with our families and with our people with CF and say, look, this is the evidence base. This is how do you want to move forward? So that's something that is outlined very well in that section, but is kind of work in progress. Do you think that's fair, Silke, to say?
Yeah, I absolutely agree, Kevin. We are not there yet to give general recommendations, and like you said, the short-term effects have shown there's no major impact, but we do not know anything about the long-term implications. And we know that many patients have reduced in their individual decisions to cut down on the inhalation therapy. But if we are asked in the clinic, we have to admit that the evidence is not there yet. And I think the CF Storm study, like you said, Kevin, is very important and will give us, I anticipate, excellent answers. It's a big study. Maybe you want to tell us a little bit more about it.
I could probably talk all afternoon on CF Storm. I probably shouldn't do that because I think we should move on because we're coming towards the end of the podcast. We should move on.
So like you said, we will get the answers. We are not there yet, and then we can give more specific recommendations. At the moment, we know from the clinical trials of CFTR modulators that all the positive effects, like you just explained so nicely, is on top of the basic therapy. So nobody knows if we reduce the basic therapies, if you still have this additive effect. So at this point, I think we have to recommend to still continue with it. And as soon as we have the data, we can really go into discussion and then write another paper, paper 5, with the new recommendations. But I fully agree, Kevin, we are not there yet.
Agreed. And I think what comes across the paper all the way through is the importance of having this open relationship with our families and a supportive environment which encourages people with CF to ask us those difficult questions, on the understanding that we may not have all the answers, but we're open and clear about what we do have.
Yeah.
So that takes us nicely onto the final section, section 7, which is around variant-specific CFTR modulator therapy. And this kind of builds on some interim guidance that we published in January 2023. And Helen, I don't know if you have that PubMed ID number, if you could put it into the chat for people so they can just get that from PubMed. I think Helen's already put in the PubMed ID number for this paper, so you can access this paper very easily from PubMed ID. And if you have any trouble accessing either of these papers, just email me and I'll send you a PDF. I'm not sure I'm supposed to say that, but so progress since the interim review has been rapid and it's been big, and this is an area that we'll need to keep a lot of attention on. But essentially, there is really good evidence to support for anybody with an eligible variant going on to ivacaftor monotherapy, or if they've got eligible variants to go on to triple modulator therapy. So this is elexacaftor, tezacaftor, ivacaftor, the triple therapy, and not included in this standards is the new triple therapy, which is going through now, which is vanzacaftor. The evidence base for dual therapies is less strong, and we've recommended that this is done in partnership with families, sort of weighing up the pros and cons of going on to a new therapy. But the evidence base for those other therapies is unequivocal, and really you should be strongly working with your families to get them access for these therapies. We appreciate in some areas of the world access is a real challenge, and that's highlighted in the paper 4 that we'll be talking about in a couple of weeks' time. What we do in this paper is we talk about monitoring for adverse events, and there is a kind of guidance with regard to how you should monitor patients who are becoming established on variant-specific therapies, and these adverse events do occur. So you kind of have to have good systems in place, and as well as the ones outlined in this paper, we've seen muscle issues, we've seen raised intracranial pressure. All these are published, but what we need is for CF teams to be diligent, to look at all things that are happening to patients who are on these new therapies, and to report them either to national or local reporting systems, and also to the pharmaceutical company who are doing post-market surveillance. So this is all really important. And there's a very good section around adjusting the dose of CFTR modulator therapy, because as you know, a pharmaceutical company can't really talk too much around adjusting a licensed dose, but this group, Mark Chilvers, Martin Hug, Peter Middleton and Jane Davis have given some really good guidance on adjusting therapies if there's been an adverse event, or if a patient isn't tolerating the therapies, how you can reinstigate them. And there's table 4, which outlines some really good advice, I feel, in doing that on a practical level. And finally, there's a small section on adjusting the dose of CFTR modulator therapy during pregnancy, but this really builds on an absolutely excellent section that was in the interim guidance in January 2023. And this is, again, a rapidly evolving field, and one that as a committee we'll be keeping a close eye on. So I do recommend that interim paper from January 2023, and we've built on that in this paper. So I'm going to reiterate the 3 key messages now, guys, and then we'll just sum up briefly. So sorry, I'll get some comments, but just to remind people that the 3 key messages that myself, Silke, and Chris have really decided on from this paper are that achieving excellent nutritional outcomes is key, and the whole CF team should work in partnership with people with CF to establish and achieve this goal through a high quality diet. So that's really important. also being ahead of the curve is really important, but didn't quite make the cut of the free because there's so many. It is critically important for people with CF to exercise on a regular basis, and that comes through this new section. And finally, as the CF landscape changes, with most people now established on CFTR modulator therapy, there is potential for examining models of care. However, access to the multidisciplinary team remains essential, and that's something that we'll be reiterating over time. So, Chris, any takeaway comments from you before we?
I think this is a wonderful paper. I think those key messages are really important. And I think what this does, that the whole paper, as I said at the beginning, it's about proactive management. It's about thinking about early nutrition and long-term health. It's about thinking about, promoting exercise from really young ages, so it becomes established as a healthy practice that then people continue to do into their adult life. And I think that really comes across for me as a really key marker. This paper is very important if you work in pediatrics to understand the role that you play in considering the impact that you're going to have, in 20, 30, 40, 50, 60 years time. So absolutely wonderful. Yeah.
And just to give a brief mention, well, a shout out for your ECFS education platform, which people should really access and is tremendous. And you're supporting us in trying to translate knowledge from these guidelines as well. Yeah,
absolutely. Yeah, and I think we're aiming to try and reduce all the barriers that we all face wherever we are in terms of education. Addressing the barrier of cost and the barrier of access and the barrier of language and time. And these kind of webinars are perfect, aren't they? Because they address all of those, or to a large degree, most of them, in a really accessible way. So thanks, Kevin, for this initiative. I think it's really been great.
Yeah.
Silke, thank you ever so much for joining today as well. I hope you've enjoyed it. It's a bit different doing it like this, not having PowerPoint slides to hide behind, but I've really enjoyed it, and I enjoyed hearing both of your thoughts. Silke, has it been terrifying?
No, we've enjoyed it. I think it was really a nice chat, and we've covered a lot in this hour. Of course, we can even talk for the next 1 or 2 hours. There are enough topics, and this paper is really multi-dimensional, but I think we covered the most important points. So thank you very much, Kevin.
And thank you for leading on this paper and for driving it forward. It was very exciting. So we'll finish 1 minute early. Next week, we're going to be talking about paper 3, and that's the paper that is reflecting on identifying and addressing CF-specific health problems. So we look forward to meeting the panel next week and to covering that topic. So goodbye, everybody, and enjoy your afternoons. Yeah.
Bye, everyone.